Hello and welcome to the Health Bridge podcast. I'm your host, Holly B. Today we are talking with Dr. Aumatma Simmons. She's a double board certified naturopathic endocrinologist who is revolutionizing fertility care. After witnessing countless couples struggle with invasive treatments, she pioneered a functional approach that addresses the root causes without drugs or financial strain. She has helped hundreds of quote unquote medically helpless couples conceive naturally. Beyond her clinical practice, Dr. Aumatma has trained hundreds of physicians, authored a best selling book, is the host of an award winning podcast, and she also created Madra Fertility. It's the world's first smart fertility analysis. Featured across major networks as the leading holistic fertility expert, she's expanding her fertile systems approach to helping professionals create abundance without burnout. There's so much to talk about with Dr. Aumatma that we decided before we even jumped onto the recording of this podcast that we were going to need to break this up into a part one and part two. Today, in part one, we're going to be talking about all about your cycle, all the stuff that you were never taught. This blows my mind, but she said she wasn't even taught this in medical school. So we're getting a really good, just like hormone one-on-one about your cycle, the different phases, what to look for in each cycle, what is happening within your body in each cycle. It's not just the standard, oh, there's the luteal phase and oh, there's the bleeding phase and this hormone's up and this hormone's down. She really gets into the details of like why this is happening in your body, what the purpose is, and what should be the normal triggering process and what each hormone triggers and all that sort of stuff. It's really fascinating. Why, again, we aren't taught this stuff just blows my mind. But that's a whole nother rabbit hole that we could go down maybe in part two. But we're going to talk about what are PMS symptoms? How do we know when we're ovulating? That sort of thing. And while those might not sound exciting or might sound basic, this is stuff that you really need to know because as a woman, we need to know and understand what's happening in our body so we can respect the process. And then we're not so likely to jump into the quick fixes, which we'll talk about in the episode of treating fertility issues or even just treating menstrual cycle issues like PMS and period pain and that sort of thing. We will be talking about what hormone testing needs to happen, what time of the month that needs to happen in, specifically what day it needs to happen on. If you want to get a true accurate reading of where you are at in your fertility journey, if you are someone that is trying to conceive or is looking to conceive in the future. We also will touch on the correlation between autoimmunity and fertility, how those two things can often be intertwined, and how there's a common root cause for both things. Spoiler alert, it does have to do with your gut. So we will get into that. And we are also going to talk about your mental space, your mind space, your mindset around fertility, as well as health issues that can really add to or take away from the struggle around fertility and autoimmunity. This is an episode that you are definitely going to want to save. You are definitely going to want to share. So I'll just ask you to like and subscribe to this podcast, save this episode, and share it with one of your girlfriends or one of the women in your life who might be struggling with this, or just maybe a young woman that you want to educate on her cycle and arm her with really positive, helpful information that will only help her throughout her life as she moves through the different phases. Now let's dive into this episode. Dr. Aumatma, welcome to the Health Bridge podcast. We're going to have a really, really good conversation today. And I already told you I'm upset that we probably won't get through everything I want to talk about.
Thanks for having me, Holly. And I'm so happy to get into whatever we can get into.
Awesome. So you are a fertility doctor, but you take a much different approach. You go the holistic route and you focus on the whole body mind connection to fertility.
Mm-hmm.
And I love that because I have seen, I'm in my mid 40s, and I've seen so many women at this point in my life who have struggled a lot with fertility. And because I haven't gone through it myself, I don't have kids, and I'm not an expert on this topic. I feel a little bit like it's not my place in speaking to my questions and my concerns when I hear women that are going through this, because I don't
Mhm.
want to take away any trust that they may have in their doctor by asking these, mind, body, spirit questions around this topic. So I love to use this conversation as a really good resource for women that are struggling, that we can refer out to women that just want to have another viewpoint on this topic.
Yeah, absolutely. I think that it's so important that we don't do this as a way to like undermine their trust in their doctors, but also holding this like piece that I see often is that women go through like 11, 12 cycles of IVF. And at that point, you have to wonder like, okay, is this normal? Like, what else? What else is missing? Because this is, it shouldn't go this far where someone is being exposed to so many hormones and so much trauma that they're going through. So, yes, I agree with you. I think it's like important to have that trust. And in this conversation, we can definitely get into how can you keep that trust and still ask the questions. And if your doctor is challenged by it, then at that point, I usually say, okay, well, it's time to find someone who can work with you on your team and be that person and that resource to be able to answer the tough questions.
I love that. And I'm all for assembling your care team. Your oh gosh, what did she call it? I had somebody on my program when I first started. She said your EMTs. You have to gather your EMTs, your excellence management team. And I thought that was
Exactly.
so great. And it's like we can get all of these different types of practitioners on your team, and we can make that all work together
Hmm.
versus having them be completely separate, or you can only do one or the other. I think
Hmm.
fertility is a perfect example, as is autoimmune, which I speak to a lot, of being that thing that really needs to have the merriment of
Yep.
both opinions, both
Yep.
sides.
Both sides. And it's not that one is better than the other. It's not that one doesn't work and the other only works. It's really like they work best when they're done well together,
Exactly.
especially in specific cases, right? Some people right from the gate will say like, "Hey, you're probably going to need IVF in addition to what we offer." And we can say that with good reasoning of like, okay, here's what we see, here's the stuff to work on. And IVF is going to speed up the process. So let's not wait on that. Let's do that simultaneously. Versus other times we look at someone who has been through like 3 to 6 rounds of IVF and we say, okay, maybe it's time to take a little pause, reset, get your body right. And then if you still need it, go back to IVF. So there's lots of ways to create this integrative mindset rather than the either or.
Even I would say a synergistic mindset. You can all work together. And
Yeah,
so
I
let's
like that a
let's
lot.
yeah.
Synergistic, yes.
Yeah. So let's dive into, I said this needs to be like a body, mind, spirit approach. Let's dive into the body aspect of
Hmm.
this. First off, because honestly, we're not really taught. Can you run us through what an ideal women's cycle looks like? What are the
Yes.
different phases? What are the different hormones that we need to know about, and how that should look in an ideal situation?
Absolutely. This is my favorite thing to do because we don't learn it at all. I didn't even learn it in medical school, which is kind of scary. Like I
Okay.
had to reteach myself all of this because was like, where was this as part of my OBGYN class?
That's a whole nother rabbit hole with no down on all the stuff that's not taught in medical school, but we'll
Oh
save
my
that for
gosh.
part two.
Okay, so the first part, we can start with, let's say, day one of our cycle is going to be the day you start menstruating. And a lot of people, even then, will have questions of like, what if I'm spotting? Does that count as day one? And spotting can be a little bit tricky. So, my rule of thumb is if you need protection, like more than panty liner, then you're in day one. If you only can get away with the panty liner or nothing at all, like you're seeing some spotting when you're wiping, then you're still spotting and it's still part of the last cycle. So that's day one. Day one, and then you can, different women have different lengths of menstruation. So anywhere from like 2 to 5, even 7 days sometimes can be normal. And during that phase, our primary hormones are going to shift downgrade. So almost everything is at its baseline where it's going to be the lowest in any point of the cycle. It's lowest at this point. With fertility, we want to test at this point because it's the only point in the cycle where your hormones aren't shifting in ways to regulate what needs to happen. So for us, like we really value that day 3 or day 4 lab test that is going to test FSH, LH, estradiol, and AMH. Those are the 4 primary fertility hormones. So a lot of women are not told that they should have tested on day 3. And we get into like back and forths all the time because I'm like, I'm sorry, it's not a day 3. And they're like, well, can you just evaluate it anyway? And I'm like, no, your hormones change drastically from day 3. And like we need to compare apples to apples. We can't compare apples and strawberries and think that we're going to have any kind of evaluation happening about your fertility. So that's really, really important. By the time that your period is closing down, like it's coming to an end, that's when the first hormone in this sequence is going to start. And that's going to be the follicle stimulating hormone or FSH. It's a signal from the brain to the ovary to produce follicles. And those follicles are basically like baby eggs, if you want to think of them that way. And your body is going to develop, depending on how old you are, how many eggs you have, all kinds of stuff. You'll have somewhere between 5 and 15 follicles that start developing. And all of them will grow and grow and grow. And as they grow, they are releasing a signal called estradiol and sending that hormone back to the brain. So the brain is detecting, oh, estrogen. And by the time you get to cycle day 12 to 14, usually in a good healthy cycle, you're going to have enough estrogen that the brain goes suddenly, okay, I have like massive amounts of estrogen floating around. Now it's time to shift from that FSH signal to LH, which is luteinizing hormone. And luteinizing hormone is the ovulation hormone. So usually that hormone will, the estrogen has signaled that LH to rise. And LH is actually only a difference in frequency between FSH and LH. It's like the same hormone, different frequency, different pulse rates. So the brain goes ding, 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 ding. And the ovary goes, oh, time to ovulate. So it releases the egg. And the way that it selected the egg is random, but there is essentially out of all the follicles that developed in that cycle, one of them was determined to be the healthiest, most vital, most vibrant possibility of a human. It's the queen follicle. So that's the egg that got released. And that egg, when it was released, left behind what's called a corpus luteum. That's the shell of the egg. It's like the protective layer that it was growing inside of. When that shell is left behind, That is what's going to produce progesterone, which is the primary hormone in the luteal phase or the second half of your cycle. So that hormone is being produced by the corpus luteum, literally the same, like co-developed with the egg. So if you have inadequate levels of progesterone, it is often a signal that egg was not going to be good quality because the corpus luteum is not doing its job. Right. So a lot of people are like focused on progesterone, especially in the fertility world. And they're like, oh, I just need more progesterone. And to me, it's a signal that you didn't get good quality progesterone if your body isn't, or if that corpus luteum, that shell is not making good progesterone. So that signal will happen ideally for 12 to 14 days. And I say ideally because the other thing that can happen frequently is that corpus luteum falls short. So instead of producing for 12 to 14 days, it produces for 10 or less. And that's where we see this, what's called luteal phase defect. I'm putting that in quotes for those of you that can't see us. And luteal phase defect is essentially this corpus luteum kind of disintegrated and stopped producing progesterone faster than it should have. So it didn't sustain the amount of time that it should have survived. Again, lack of blood flow, lack of right nutrients, and lack of egg quality is going to cause that luteal phase defect. That progesterone is being produced, and then the corpus luteum essentially at the 14-day mark in an optimal cycle will say, oh, I don't think a pregnancy happened. If pregnancy happens, a feedback loop is sent literally from the uterus to the ovary. And that local feedback loop makes the corpus luteum stay alive essentially for longer, for 10 to 11 weeks. If that signal did not go back to the ovary, then the corpus luteum says, I don't think anything happened, so I'm going to die off. And as soon as it stops producing progesterone, hormone levels drop, progesterone level drops, which signals the shedding of the uterine lining, which is then going to get us back to day one.
That was a much more understandable but in-depth explanation than I'm used to hearing. So thank you for that. Honestly, I don't think I've ever heard about that shell being what like releases or triggers the progesterone
Yeah.
production. So that's super interesting. Okay, so if this is what a standard cycle should look like, how how do we know if we are off? So we're talking
Mhm.
about PMS symptoms, we're talking about ovulation symptoms.
Yeah.
Like I've
So
never
many.
known, I know, I've
Mhm.
never known actually when I'm ovulating. And I didn't know that
Mhm.
that wasn't kind of normal. But I've talked to many women at this point who are like, "Oh, I always know when I'm ovulating." I'm like, "I have no idea."
Yeah,
So what does
yeah.
that tell
So
you?
we can tell us, well, one is, I think a lot of us don't know because we're never taught what it looks like or feels like. So we can definitely talk about the signs and symptoms that might be present that would signal ovulation, even if you're not super focused on tracking it. The other question is around symptoms and what an abnormal, quote unquote, cycle looks like. So, a cycle length that is shorter than 25 days is usually not ideal and not normal. So, when you have a short cycle, that's an immediate signal of like, hey, probably something is going on. Maybe you're having anovulatory cycles, which is why there's no progesterone in the system to sustain a longer cycle, or that corpus luteum is dying off quickly and you have that luteal phase defect. And both of those can be problematic, especially if you're trying for pregnancy, but also problematic earlier in life. So if someone's having a 20-day cycle, for example, that can be a big red flag in terms of how many eggs they're kind of shedding or like utilizing very quickly, right? And if you do that your whole life, probably by the time you get to 35 and you're like, how come I can't get pregnant? You may not have any more eggs left, right? So that is a really big signal. The other big signal is irregular cycles from the aspect of length. So let's say every other month you have a 40-day cycle and every other month you have a 20-day cycle. And you're like, I can never tell, but it's pretty like I've heard people say, well, it's consistent. And I'm like, it's consistent, but it's random. It's still like 40-20, 40-20, even if it has a rhythm to it, it's not consistent from month to month, which is what we're looking for. So those are easy to pick out because they're just based on cycle tracking. And you can literally get whatever one of those free apps that tracks your period and you're like, "Oh, my last month was 28 and this month is 32 and next month is 50." It's a little bit all over the place.
Really quick, Holly B here. I just wanted to interrupt the podcast to ask you for a quick favor. Can you take just a moment to like and subscribe to this podcast on whatever platform you are listening in on? It makes a world of a difference. And the reach of this podcast, it takes like literally under 10 seconds. So go do that right now. Thank you so much. I really appreciate it. And now back to the episode.
The second signal that a lot of women, I think, are told that this is normal is PMS. And PMS can vary, right? PMS can be everything from symptoms with your menstrual, like leading up to your menstrual cycle. It's symptoms of emotional lability or like you feel moody, you go from happy to sad in like a drop of a hat, or you start crying for no reason. All of those are considered quote unquote normal. In a healthy cycle, those should be very minimal. That doesn't mean they don't happen. If you are in tune with your hormones, then you'll almost always be like, oh, yeah, something's shifting, right? Like I feel a little more sensitive. And that's often because our hormones are shifting. In addition to that progesterone, what I should have said is also estrogen is part present in the luteal phase, which a lot of us forget. But if that estrogen is higher than the progesterone, then we're going to have an increase of these hormonal quote unquote symptoms because that's the part of the cycle when we're not supposed to have estrogen that high. Estrogen's fine high in pre-ovulatory phase. After ovulation, progesterone should be the predominant hormone. So when that progesterone is present, but estrogen is overshadowing it, it's really easy to like our body triggers this weird response of like, well, I don't know which way to go. So I'm going to like flip flop basically. And it doesn't feel good. So that's where we get a lot of those symptoms. But a little bit of sensitivity is okay. I'm a little bit more touchy feely, emotional, whatever. Like all of those things are relatively normal. Um, then we have the actual blood flow. So when we start bleeding, we have what's the color of the blood? Is it bright red or does it start with brown blood, which then slowly turns to red, or does it start red and turn brown? And all of those are going to be abnormal. Ideally, it's red flow right from the beginning and it stays red until it ends. There's no brownness as part of it. That's usually like old blood that didn't actually shed fully in the previous cycle. So we don't want that. We also don't love when there's clots present. That tells us there's a lot of stagnation. And I can tell you on a personal level, like I was seeing a lot of clotting and I was like, okay, you know what? I have to just increase my degree of movement while I get into my period time because I tend to sit a lot. There's a lot of stagnation in the pelvic region, which is then going to lead to stagnant blood flow, which is not healthy. So, clotting is usually a sign. And then the biggest sign that something is very much out of whack is pain. And a lot of women are told pain is normal with their cycle. But if you are, I think that there's a degree of pain that's normal, and that degree of pain is probably like a 2 to 3 out of 10. If you're experiencing a 7, 8, 9, 10 out of 10 pain, that is very abnormal. And that is not, I see a lot of women that are like, oh, I have a 2 out of 3 pain. And then if you ask them, like, what are you doing? Or do you do anything? Are you taking something? And they're like taking 2 Advil every 3 hours to manage the pain. And I was like, okay, so what if you don't take the Advil? And they're like, what? Like, that is not a thing. I am never not taking Advil. So we have gotten accustomed to this culture where we tell women that it's normal, and then when they're like, oh, it's a lot of pain, so I'm gonna like self-manage with over-the-counter pills that are gonna help lower the intensity. So not normal. If you need to manage with pills, even if they're over the counter, that is very much, to me, a sign that something is out of whack. It's often the hormones, it's often prostaglandins that are basically like inflammatory molecules in our uterus that are triggered by progesterone, and estrogen triggers a different molecule called histamine. So between those two, like if that happened in the luteal phase and it went kind of haywire, you're almost always going to have a lot of pain in that first part of your cycle. And it is fixable. You just need to know what's happening in order to manage it and fix it. So that those are the big things, I think, as far as like what your cycle can tell you.
I
Ovulation. Oh, sorry, go ahead.
I just want to jump in because I'm I just feel upset about how I was handled when I was young, starting my period.
Yeah.
My mom brought me to the doctor because I was doubled over in pain. I had to come
Yeah.
home from school, and so we go to our pediatrician, and he says, "Oh, well, if you just try just taking some Aleve right at the very beginning of the pain." So I did, and it worked like magic. And from there on out, that was my answer to everything, not just my monthly cycle pain, which was unbearable without the pills, but to everything else. And I mean, I lived on any slight tick of like this could get uncomfortable. I was reaching for the Aleve or the Advil. And I was like that through my mid 20s, early 30s at least.
Yeah.
And I just think what a disservice that
Yeah.
was, you know?
Yeah. Yeah, absolutely. And I think that it's so normalized, and if we didn't get given over the counter pain relievers, we were given birth control. So those are the two kind of go-to options in the women's health world that I think both of them are a disservice in a lot of ways. One is the pain relievers have a damaging effect on our livers. What's really interesting that women, if you're trying to conceive, what you don't want is to be taking something that's going to affect your ovulation. And oop, and there was a study that came out in this is probably like 6 or 7 years ago now, that basically said that if you took more than 5 aspirin, Aleve, ibuprofen, literally like all of the non-steroidal anti-inflammatories, if you took more than a certain amount, you were disrupting ovulation for that cycle. So basically, like, take the pain relief because you're trying to get through your menstrual cycle. But if you're trying to get pregnant, it's affecting your ovulation. That's probably not a great thing.
So it's
So,
perpetuating the whole issue.
yes, exactly. Exactly. So, yeah, we are living in a world where we have really awesome medications that temporarily fix the problem, but I say anything that comes too easy is going to have a downside somewhere. And that's true for everything. right? I was saying on a different podcast, I was like, even AI is going to have a downside. And the downside is it might make us dumber. Like right now, it's great because it saves me time and energy and effort and all of these things. But over time, it's probably going to make me dumber. So we really have to think about the things that we add in that every time we're like, oh, we have, like I have all these electrical things that help me have an easier life, but they're all releasing EMFs. That's going to have a downside. It's really like the things that make it more convenient, more easy, more tolerable, whatever we're trying to like get rid of, what's the downside of it? And sometimes those downsides are not noticeable right away, right? So until they did the study 7 years ago, no one had ever considered what is the effect of these the NSAIDs or over-the-counter pain pills. What effect is that having on the rest of the hormones in that cycle? So, yeah, it's
Yeah, it's
unfortunate.
wild. It's wild. Again, I love that you speak to these things. I think I cut you off right as we were getting into ovulation, so I want to
Yep.
make sure we touch on that too.
Yeah. So ovulation is the fun part of the cycle often. So some people will report that they feel a twinge when they ovulate. If you feel more than a twinge, like you're in a significant amount of pain, that's not a normal thing. But a twinge for a couple of hours is okay. That's quote unquote normal. But not everyone experiences that. So what are some other signs and symptoms surrounding ovulation? I think the human body is amazing. So, one of the very early things that I feel like we are missing in the physiology of things is the rise in testosterone. And there's almost always a rise in testosterone prior to the rise in estrogen. And testosterone is actually the precursor to estrogen. So, like the brilliant design of our body is that estrogen, when it reaches its peak, is going to trigger ovulation. But our body is designed for procreation. So the testosterone actually starts surging just before estrogen, and it's the building block of estrogen. And that testosterone is going to increase your sex drive. So, a natural rise in sex drive around your ovulation, usually like 5 days before you ovulate, is actually a very normal and very healthy sign that you're going to ovulate soon. It's like nature's way of ensuring that humanity was going to survive, right? They're like, hey, if we get your sex drive up, you're going to have more babies. So, that happens almost all the time, unless something is wonky about your hormones. And that's probably my favorite sign. I love seeing that in women because that to me is the sign that we've addressed all the other issues. If you're stressed, your testosterone will not rise because your body is literally stealing the precursors to testosterone. And you may still get estrogen surge, but you won't get that testosterone surge. So a lot of people come in with, I have zero sex drive. I don't want to have sex ever. And if we go from that to like, you feel like you want to have sex like 4 to 6 days out of the cycle, especially when it's pre-ovulation, that's like perfect. Not to say that you shouldn't have a sex drive all the other times, but it is often off the charts to the point where women will be more likely to initiate sex during that time period than any other time of the cycle. So that's a really good signal. And then the second thing that happens is as the estrogen starts to rise, which is about 3 days before ovulation, you will start to see cervical fluid. And cervical fluid changes very quickly, but it starts out kind of thick and mucousy. And as you get closer to ovulation, it will thin and become this, they call it egg white. I never really understood it, but it's like thin and stretchy. And then post ovulation, that cervical mucus actually becomes a plug for any further sperm making it into the cervix. So that cervical mucus gets thick and sticky and tacky, and that is actually the closing of the cervical window or the ovulation window. So you have this about 7-day period where you're seeing more like release of discharge, and you can track it if you want. There are like people that will say, "Oh, we want to measure it and like see how stretchy it is and all that." I'm like, "Yeah, pass. I'm not sticking my finger up there every single day." Pass. So it is, I think, relatively noticeable if you're just like observing your panties and seeing like, "Oh, I have a discharge, so I discharge." And then around that like ovulation day, it's almost like every time you wipe, you are feeling more like discharge that doesn't like fully wipe and it's more slippery. That's the fertile cervical mucus. So that's like ovulation day, maybe a day before. So you'll start to see that relatively easily in most cycles. And then the third sign is going to be tracking, if you're tracking your temperatures. So you get a 0.5 degree to 1 degree rise in temperature from your follicular phase to your luteal phase, which confirms that you've ovulated. So that's the last sign. And unfortunately, like that takes a little bit more tracking than the average person does. But if you're trying to conceive, that's a really good thing to track.
And so if we are looking to get our hormones tested to just see where our levels
Yeah.
are we going to the gynecologist, the OBGYN, or are we going to the endocrinologist? That might be
um,
a tricky question. I don't know.
or yeah, or at all.
Or not.
So the rule in the women's health world is that your OBGYN, your gynecologist, will offer you hormone testing. They will almost never tell you on to go on cycle day 3, so just know that and go on cycle day 3. Don't even ask, just go on cycle day 3 or 2 or 4 if you need a little bit of a leeway. But they will not offer that testing if you are under the age of 35. You have to have tried to conceive for 12 months, or if you're over the age of 35, then you've tried to conceive for 6 months. And that testing is not available to most people until they get through those markers, which,
And
if you
when you
think about,
say, sorry,
yeah,
and when you say this testing, well, you'll tell us specifically what testing we're to
yeah,
ask for.
those were the ones that I mentioned before. So the 4 standards that we need is FSH, LH, estradiol, and AMH. Sometimes a prolactin is nice to have on there, but it's a bonus. So FSH, LH, estradiol, AMH. And those 4, again, want to be done on day 3. You, if you are waiting for your doctor to do that testing for 12 months of trying, I guarantee like every single person that I've talked to is like, "Oh my God, can they just do it faster? Like, why do I have to wait 12 months to do this testing?" And what you're essentially waiting for is for insurance to cover the testing. So there are lots of like direct to consumer places that you can go and get this testing for like $150. Not a lot. And you're basically waiting 12 months to keep trying before you get this test offered from your doctor, which, if you're trying to conceive and if you're at that phase where you're like, I really want to have baby, you don't want to wait on this testing. Like, I personally think that we need these tests on a yearly basis so we can see what's happening and get a baseline of hormones and see what our hormones look like and just like check in. But until that changes, until we get to the point where we're even being offered if we're trying to conceive, we just have to like do it on our own and be okay with the $150, which sounds like a lot, but in the grand scheme of things, it's going to save you time. It's going to save you lots of money potentially. And really put you ahead of the game if you're like, oh, my hormones are out of whack. Who should I go see? What should I do? How should I fix this problem? You're going to be asking those questions a lot sooner if you didn't wait for that testing for 12 months. And now you're like at the end with your wits end and you're like, I wanted to have a baby 12 months ago. I still don't have a baby. Like, let me just go to IVF at this point. So people are so frustrated and so like disappointed on this roller coaster of trying that I think they give up before they even have looked into anything because they literally waited 12 months to do the basics.
Hey, I just wanted to jump in here and interrupt the program for just a hot minute. You know that I'm so passionate about this podcast, but what I'm also really passionate about is helping women with lupus minimize their symptoms, boost their energy so that they can indulge in life again. So if you are a woman who is struggling with lupus, who is sick and tired of being sick and tired, who's struggling to manage your flares, if you're finding that your lupus symptoms are just really getting in the way of you being able to live your life the way you want to, I feel you. I've been there myself and I felt the same way. And what I've found is that there are a certain set of health fundamentals that once applied, will support you in your foundational health. They will support you in building and maintaining that energy, minimizing flares, and allowing you to, again, indulge in life and follow your passions. So, if that is something that you are interested in creating for yourself, let's jump on a call together. I will walk you through the process that I use with my clients to get them from sick and tired to strong foundation of health by implementing my Health Bridge protocol. If this is something you're interested in chatting more about, I would love to talk to you. Apply for a free clarity call with me, and I look forward to getting to know you soon. And now back to the episode. Right. And then they just feel the need to do the quickest fix, which
Yeah.
most people will say, oh, try IVF.
Yep. Absolutely.
And I know that hormone testing once you're in perimenopause, menopause might look different.
Very
Can you
different.
touch on that?
It's hormone testing in perimenopause is very different. And you're probably going to do it on cycle day 19, which is right off the bat very different. Um, but the funny thing about hormones is like I've specialized in fertility for so long. I'm like, you're in perimenopause, you're past what I can help you with. It's a completely different way to interpret hormones, very different ranges of optimal. You're looking for very different things. So I talk to a lot of my perimenopause colleagues and they're like, oh, but don't you blah, blah, blah. And I'm like, don't want to hear it. I don't want to know because it's like drastically different from fertility. And I think this is a detriment to what a lot of people don't understand is like if someone specialized in perimenopausal hormones, they're not a fertility specialist. And for someone like me who's like so deep in the fertility world, people always are like, "Oh, but you can help me with perimenopause and menopause." I'm like, "Yeah, no, no thanks. That's not. I can point you to 12 different people who do that, but it's not me." So I very much am like a purist when it comes to understanding hormones because if I start trying to memorize and remember like what's optimal for all these different phases of life, I'll just be confused.
Yeah, but that's also really good to know. So if somebody's going to their OBGYN that helped them through fertility and now they're in this next phase, it might be for their best interest to look for someone that has more of that specialty.
Yeah.
Yeah.
And definitely when I see this a lot with OBGYNs are actually a lot of them like to work in that perimenopause menopause phase. And it's because there's a kind of a surge of like hormone replacement therapy, even if they're bioidentical hormones, it's a lot of hormone replacement therapy, which is so different from fertility because in my world, I'm like, well, I don't want to replace your hormones. I want to get your body to make the hormones. There's no reason you can't make them. So it's like, it's two different ways of thinking about it. And it's okay that replacement is okay in that perimenopause, menopause period because our bodies actually stop making them and it's normal to stop making it. Whereas in the fertility period, not normal. Like your body should know how to make these hormones. And if
Mhm.
it's not, it actually needs retraining and getting on training wheels and being like, okay, how do we get your body to do this? Or why is it not doing it?
Yeah,
And yeah.
that's a great way of looking at it. We're almost at the top of the hour, so I know we need to wind this down. And like I said, there's so much more to get into. So I would love to schedule a part two with you because there's so many lifestyle nuances that
Mhm.
come into play to retraining the body to create this hormones or to release hormone excess like estrogen. But I'd love to touch on the complications that come into play with fertility and autoimmunity,
Yes,
because I'm sure that's something that you see. And I know,
feel it.
with a lot of women that I speak to in the autoimmune world, sometimes they're told they aren't going to be able to have kids. Sometimes
Mhm.
they can. Sometimes that is the trigger for autoimmunity.
Mhm.
It's
It's
a
so
whole
much.
interesting, yeah. So I'd love any insight that you can lend to this.
Yeah. So what we see a lot is Hashimoto's and how that impacts fertility. And Hashimoto's is interesting because a lot of women have completely normal, quote unquote, thyroid function. They may even have normal TSH levels, T3, T4 levels, and yet their body is still creating antibodies to the thyroid gland. And what most doctors are looking at is like, well, your TSH is normal, so we don't really care. It doesn't matter. But what we see is that women that have antibodies to thyroid, for example, and we can extend this out to like antibodies to anything in your body, is often enough of a trigger to create antibodies to the embryo that your body has allowed for implantation to happen. And often we'll see a higher rate of pregnancy losses in women with autoimmune conditions. Our approach with it is really to dial it back and say, well, why is your body creating these antibodies to begin with? And so much of that, and you probably see this a lot, like so much of that is going into the gut. And the gut is the first immune barrier in a lot of ways. The skin is the first, but internally, the gut is the first barrier to things that are going to affect the immune system. And there are there is a lot of evidence that when we have intestinal permeability, when we have infections in the gut or specific microbes in the gut, all of those are going to make it likelier that the the gut's immune system gets a little haywire and starts triggering this autoimmune reaction. And then that immune system is just trying to attack something. And it doesn't mean to attack the thyroid or it doesn't mean to attack a specific part of our body. It just does it by accident almost. So the way to fix it is let's figure out what is triggering your autoimmune reaction. And if we can dial it in into a way where the gut immune system calms down, it stops overreacting, then often we'll see like the peripheral antibodies get lower, but it started with the fixing and healing the gut and really getting that immune system to calm down. So, yeah, so we'll see that a lot and we see really good success with women who have antibodies that were off the charts and then the antibodies go down and they're like, "Oh my God, this is amazing." And like they see them going down, but it's just a response of like, "Hey, your gut is healing. Of course, those antibodies are going away."
Absolutely. And one thing that I think you speak to, and something that I speak to a lot that applies to both autoimmune conditions as well as fertility issues, is your body is not broken. You're not
Yes.
broken. There's nothing innately wrong with you. We just have to reestablish the communication within your body. As you said earlier, we have to retrain the body systems to optimal functioning. And
Yeah.
so I think we're given this mindset that something's wrong with us, innately wrong with us, when we can't produce a baby because isn't that what a woman's body is designed to do? Or
Mhm.
we can't function normally, when we have an autoimmune condition, like quote unquote everybody else. Why can't we just be normal? There's something innately wrong with me. And I think that it's so important to address that aspect of this whole conversation too with our patients, with our clients around this, because if we're going into everything with that mindset, we're already blocking some of the possibility of
Yeah.
creating that shift. And so,
Yeah.
addressing a healing mindset while doing all of this holistic stuff, all the lifestyle stuff, even the Western medicine stuff. We have to work on that mindset shift in order to allow all of that stuff to really take hold within our bodies and make that huge shift
Mhm.
that we know it
Mhm.
can, right?
Yeah. Yeah, absolutely. I think I like to reframe it from is my body broken to what is my body trying to tell me
Yes.
about being safe?
Yes.
And if we reframe from that first question to the second, then almost always we're asking the questions that are going to get us to reveal the answer instead of a fixed mindset of, well, I'm broken and I can't be fixed, or this issue needs a fix that involves like really intensive hormone therapies or whatever, medications, all kinds of ways that we try to like fix what we think our problem is, but we haven't asked the question of like, what is it trying to say and what's underneath all of this?
Mm, I love that. I mirror that 100%. I'd love to do a part two with you where we really go through those lifestyle shifts. Can talk about sleep. We can talk about the gut. We can talk
Mhm.
about nutrition, specific deficiencies, all of those
Yeah,
things
so much. Yeah.
that can help to retrain our bodies.
Yeah.
So we'll plan that. But what do you have any last thoughts for our listeners that might be struggling in this arena or know somebody that is? What final thoughts would you leave with them?
I do have a thought actually, and I think I was, we were talking about it in terms of lab testing, but in general, I feel like so much of our innate wisdom or our innate intuition about what's happening in our bodies is overtaken or overshadowed by what the doctor said, what my parents said, who this other person said, or this person in a Facebook group. Like we don't even have to know them to like give our power over to them. But instead just saying like, okay, if I like what is my intuition saying about this? Do I feel like there might be something going on that is potentially going to make it harder for me to get pregnant? And if your intuition is saying yes to that, then don't wait to do the testing. Don't wait to find the resources. And we can link it in the show notes. One of the resources that I've been working very hard on creating is a smart fertility analysis. It's basically a free resource to figure out what's at the root of fertility issues. So for anyone, and you can use this for period weirdness or, like all the things we talked about that may not be normal, it will analyze all of it and it will spit out like, here's the top 3 things that we think you have going on. You can do further testing if you want. You can address this with diet, lifestyle supplements if you want. But taking action instead of waiting, hoping. And what I find in the fertility world is like before you know it, you've been trying for way longer than you thought you would need to. And you're like, shit, I still don't have any answers. So get those answers because I feel like we stay stuck in this hamster wheel, feeling like, oh, the next cycle will be different. The next cycle I'll get pregnant. The next cycle something will shift. And that's true sometimes, but sometimes there's actually things going on that are going to keep you on that hamster wheel for years. And I'll see people like who have been trying for 2, 3, 5 years before they come and seek out help. And I'm like, dang, if you came to me 3 years ago, we really had a chance. And now it's like way harder, way, way, way harder. So don't wait. Like fertility is one of those like very time sensitive issues. And a lot of times we're like, you don't actually have anything. Just you're good. And all of those people that I have talked to that I was like, you don't have anything, everything looks good, go try for a little while. They'll come back within a month or two and are like, I'm pregnant. And I'm like, well, what happened? And they're like, you just relieved like whatever mindset thing I had of something is wrong with me enough for me to like actually like have a different response in my body. So sometimes like it's better to know and then feel like, oh, actually everything's good. Great. You spent $150 to know that everything is great. Well worth the money.
I love it. I love it. Yeah. And again, that just goes back to that mindset aspect that's just so important, I think, in setting the stage for healing, for pregnancy, for a positive life journey, no matter what aspect of life you're talking about, right? So
Mhm. Yeah.
this has been an amazing conversation. I can't wait for part two. So, and I'm
Yay.
excited to put that link in the show notes for everyone. That sounds like an amazing resource. So, thank you so much for being here.
Thank you for having me, Holly.
Did you learn something new about your cycle that you didn't know before? I certainly did. And it also just triggered so many memories for me. Now that I'm in my mid 40s, it triggered so many memories for me of like places in my life where the ball was dropped. Either I didn't know to ask, I didn't know to seek help, I didn't know where to seek help or who to ask, or just places like with that pediatrician that just really dropped the ball and let me down. And I think there's just so many implications here for where Western medicine just isn't up to speed. As she said, she doesn't even get taught this in medical school, right? And that's again such a bigger conversation that we can have. And maybe I can find the right person to do that with on this podcast, or maybe we'll be able to get into it on part two. Medical research is pretty much, until more recently, is pretty much only centered on male physiology. And so, why would they even study female hormones? I don't know why. We can theorize on why. We can theorize on why it wouldn't be beneficial to empower women with knowledge about their own bodies. I'll just leave that thought with you and you can take it where you want. But we need to change that narrative. And we change that narrative by having conversations like this, by seeking out practitioners who are well versed in these topics, who can speak to women's hormones. I think it's just so important, again, that you share this episode with somebody that you care about because we need to get this information out there. I'm curious how you will take this information, how it's empowering you, and if you will maybe approach your cycle a little bit differently from now on. I'm also curious if you are in a fertility struggle or on a fertility journey, or if you are autoimmune and struggling with fertility as well. I'd love to hear your story. So please leave a comment and let us know if this is something that has affected your life. And also, working with someone like Dr. Aumatma or someone like me who is really keen to get down to those root cause issues that are affecting your autoimmunity that are affecting your fertility, it is so important to do that in combination with your Western doctor because, as we talked about in the episode, it takes a balance of both sides to really start making true change in your health condition or in your fertility journey. So I encourage you to utilize all the resources that we have in the show notes from Dr. Aumatma and also apply for a call with me. If you are on a health journey of your own and you are ready to get down to some root causes and to really start making lifestyle changes that will have a positive effect on your health condition, let's talk. As she said in the episode, it's so sad when she sees somebody that just waits so long to get the answers that will actually help them. I don't want that for you. I don't want you to wait any longer to address the symptoms that are holding you back from really allowing your light to shine to the world. The world needs your light to shine to become a better place. So let's start with a call. I have the link in the show notes to apply for a call with me. I can't wait to talk to you. We'll dive in and see what your health journey looks like so far, what your goals are, where you want to get to, and let me show you a trajectory that will get you there. Okay? Make sure you look out for part 2 of this conversation with Dr. Aumatma. This is when we'll start diving deeper into the lifestyle issues that can contribute to fertility struggles and also to autoimmune struggles because they're largely the same things. And so we will really get into nitty-gritty details on things that you can specifically do to uplevel your fertility journey and your autoimmune health. Thank you so much for listening, and we look forward to having you on the next episode of the Health Bridge podcast.